Thank you very much, John. So good afternoon, everybody. So I will extend the presentation of Maurizio Cecconi to the clinical setting. First of all, I would like to declare that I'm a member of the Medical Advisory Board of Perfusion. So you know that, maybe you don't, but Maurizio Cecconi is the first author of one important paper with very prestigious authors like our chairman, Massimo Daniel De Baccaresson. And this is a report of a consensus conference recently published in Intensive Care Medicine, recommending for this part not to target any absolute value of ventricular filling pressure or volume when you decide to give fluid to patients, but better to use dynamic over static variables to predict fluid responsiveness when applicable. Dynamic means pulse pressure variation, means passive leg raising, means and expiratory occlusion tests, etc. In fact, what we need when we plan to give some treatment to patients and maybe fluid to patients is to know about the slope of the Frank-Starling curve at the time you plan to give something. And this is why dynamic indices of preload responsiveness have been proposed, to know about the slope. So you have to perform a test to know the slope, because you need 2 points, one baseline and one another point to know what is the slope of the Frank-Starling curve. And this is why we use some tests, passive leg raising, because you mobilize some venous blood towards the intrathoracic compartment, like a free challenge, or some heart lung interaction indices, because mechanical ventilation is able to change preload over the respiratory cycle. Very small changes in preload, and therefore you can look at the changes in stroke volume at the same time. And if you cannot measure stroke volume, you can take pulse pressure instead of stroke volume, because pulse pressure is proportional to stroke volume. And the changes in pulse pressure during mechanical ventilation could reflect the changes in stroke volume during mechanical ventilation, because the other component, which is arterial compliance, does not change over the respiratory cycle. Therefore, we can pay attention to the respiratory variation of stroke volume or surrogates like pulse pressure. So, if we have a high pulse pressure variation, we can assume that the patient is preload responsive and fluid responsive. If we have a small pulse pressure variation, PPV, we can assume that the patient is not fluid responsive. And this is a paper, two papers we published years ago in the Blue Journal, and proposing the calculation of pulse pressure variation as a difference between the maximal value of pulse pressure minus the minimal value of pulse pressure, and divided by the mean of the two values. And you can use any arterial catheter to do that, or any device that measure blood pressure. And using PPV, pulse pressure variation, before giving fluid to patients with septic shock, we observed that PPV was higher in patients who will respond to fluid administration in comparison with the other ones. And we found a threshold value of 13%. And in terms of area under the row curve, it was better than central venous pressure, CVP, or PAOP. And this is a meta-analysis published last year in critical care, looking at all the studies that use PPV as a predictor of fluid responsiveness. There are 22 studies in this meta-analysis, and the authors found that the area under the row curve, the average area under the row curve for the 22 studies was very good, 0.94, and the threshold value they found in this meta-analysis was 12%. So very close to the value we found years and years ago. What is interesting is that not only you can predict fluid responsiveness using PPV, but you also can predict the degree of fluid response, because there is a close relationship between the changes in stroke volume or cardiac output induced by fluid and the value of PPV before. The larger the PPV before fluid infusion, the larger the increase in cardiac output after fluid infusion. And the opposite is true. The smaller the PPV before, the smaller the increase in cardiac output after fluid infusion. So you can predict also the amount of increase of cardiac output. And there is a gray zone where you don't know. And you can suppose that because it is between 8 and 13%, you can suppose that the patient will respond, but a little only. Never an explosive response. This is a tracing of PPV, delta PP, in a patient before giving fluid, 32%, which is a huge value. And after, we observe the decrease in PPV from 32 to 5%. And what is interesting is that if you use PPV, you can not only predict, but also you can follow the changes in cardiac output. Because now at 5%, you can say, okay, I stop fluid administration. And there is a nice relationship between the changes in cardiac output on the x-axis and the changes in PPV. So if you have no cardiac output monitor, you can use PPV. For example, during anesthesia, it is possible to do that because you can also follow the changes in cardiac output induced by fluid infusion by following the changes in PPV. Now we have many devices able to calculate automatically and to display in real time the value of PPV on the screen. Also we have, and Maurizio also mentioned this variable, which is SVV, stroke volume variation, because we know that we have devices able to calculate stroke volume using the arterial pressure waveform analysis. And we also can have the value of SVV on the screen and in real time. And this is another meta-analysis by Paul Marick and co-workers comparing the predictive value of PPV, SPV, which is systolic pressure variation, SVV, and the other static variables. As you can observe, the dynamic variables are far better in terms of prediction of fluid responsiveness than the static variables like CVP, for example, in terms of area under the row curves, which takes into consideration sensitivity and specificity. We also can use some non-invasive devices. For example, we can now measure non-invasive finger blood pressure using some very simple devices. And with the SYNAP system, with Xavier Monet, we observe that the PPV-NI, which is non-invasive PPV, measured by the system, performs as well as the invasive PPV. So it is a very good news, especially for the surgery patients during surgery. We also can use the esophageal Doppler, and if we use it, we can pay attention to the changes during mechanical ventilation of aortic blood flow or aortic blood velocity, depending on the device. And with Xavier Monet, we also show that delta ABF in percentage was a good predictor of fluid responsiveness. As you can observe, when you have a high variability, you can respond to fluid administration. When you have a low variability, you are not a fluid responder. Also, we can use traditional, conventional echocardiography, and if you do that, you have to pay attention to velocity time integral and the peak of velocity, for example, and you have to look at the variability of this peak. And with Marc Fessel, we showed that responders to fluid administration had, before fluid infusion, a higher variability in the peak of velocity, and we found a value of 12% to discriminate between these two categories of patients. Also, we can use a pulse oximeter And you know, the Massimo company is not the name of our chairman, but a company proposed to calculate automatically and to display on the screen of this monitor the value of PVI, which is plate variability index. It is using the plethysmographic signal. It is very simple to do. It is a non-invasive device, of course, and this performs as well as PPV to predict responsiveness during anesthesia. And this is a meta-analysis by the group of Massimo Antonelli this time, and looking at all the studies that use the pulse oximetry and the variability of the signal to predict field responsiveness, and they found that in terms of area under the ROC curve, sensitivity and specificity, it was not so bad. And so you can use it. But if you use it, be careful in patients receiving vasopressors, like norepinephrine, for example. It does not work very well, and with Xavier Monet, in patients with septic shock, we observed that PVI was not as good as PPV and SVV to predict the responsiveness. You observe the area under the curve is not so good. So be careful in patients receiving vasopressors. You also can use the respiratory variability of the inferior vena cava diameter using echo. It is very simple to do, and you can have the answer of your question. Patients with a high variability are field responders, and the opposite is true. Also, if you perform a transesophageal echocardiography, you also can assess the variability of the superior vena cava now, and you can pay attention to the collapse during insufflation of the vena cava diameter. And Antoine Villard-Baron and co-workers look at that and show that the SVC collapsibility, which is an index of collapsibility, was as good as PPV, pulse pressure variation, to predict responsiveness in patients receiving mechanical ventilation in septic patients here. But of course, they perform equally, but of course, you need transesophageal echocardiography to do that. And in my opinion, it is better to use PPV because it is easier. This is a meta-analysis by Benesch and co-workers looking at the clinical interest of PPV and SVV in patients during and after surgery. This is a group of a list of studies, many studies, and interestingly, they show that when you use an algorithm using either PPV or SVV in comparison with standard care or standard monitoring, you can decrease the post-surgical morbidity, you can decrease the rate of infectious complications, also the cardiovascular complications, and also the abdominal complications, and the ICU length of stay. So it is a very good news for surgical patients. In ICU patients, and especially in septic shock patients, we have not so many studies. We have one study published this year in critical care by the group of Jean-Christophe Richard and Claude Guérin. They randomized patients, one group, which is a control group. They resuscitated the patients using the CVP, essentially, MAP, etc. And another group, which was a preload dependence group, and the patients were resuscitated according to PPV when applicable or passive Lagozing test. And as you can observe, there was 30 patients in each arm. You can observe there was no difference in terms of mortality, but the p-value is very, very good, 0.07. So it's not so far from 0.05, and there are only 60 patients. So there is a signal for the improvement of survival using PPV or passive Lagozing here. And interestingly, also, they observed a decrease in blood lactate, which was more significant in the preload dependence group in comparison with the control group. So this is also a very interesting result. Another result is a difference in intravascular volume expansion per day. And there are less amount of fluid which were infused in the preload dependence group. But when we look at the results according to the severity of the patients, it is very interesting to observe that patients with less severity receive more fluids in the control group using CVP than the preload dependence group. But patients with high severity, high substitute score, receive more fluids when they are in the preload dependence group in comparison with the other group. Of course, and as mentioned by Maurizio, there are many limits of the use of PPV and SVV, for example. There are some false positive, like right ventricular failure, for example, some false negative, like low tidal volume ventilation. And of course, it's not possible to interpret these indices in patients with spontaneous breathing activity, in patients with arrhythmias. It is difficult to interpret if tidal volume is too low, especially when the value of PPV or SVV is low. Also, if lung compliance is too low. Also, in case of high-frequency ventilation, in case of open chest conditions for obvious reasons, and also we have to be very careful in case of severe right ventricular failure. But the good news is that we have other tests to do in this difficult situation. And for example, we can use the hand expiratory occlusion test. Maurizio already explained what was this test, so it is very simple to understand, because you know that at each mechanical insufficiency you have a decrease in preload, which is the general physiology. So if you interrupt the ventilator at the end of expiration, you should prevent this decrease in preload. You prevent the increase in the decrease in systemic venous return, and the heart senses this situation as an increase in preload. And therefore, it is very easy to identify fluid responders and fluid non-responders if you measure cardiac output or stroke volume during this very brief maneuver, only 15 seconds. And therefore, you can identify fluid responders by the increase in cardiac output during this maneuver. And patients who are not fluid responders do not increase their cardiac output. This is what we confirmed with Xavier Monet in a paper some years ago, and we could well discriminate responders and non-responders by the increasing cardiac output during this hand expiratory occlusion test. And we found a 5% value as a threshold value. And you can do that with any real-time cardiac output monitor. In this study, we use a PICO, but you can use any others. And it is interesting because it can work when PPV cannot. This is a study we did with Xavier Monet again, and we looked at patients with low respiratory system compliance, no low lung compliance, but ARDS patients with compliance of less than 30. And PPV did not work in this situation. You have to look at the area under the row curve, but the effects of hand expiratory occlusion test on cardiac output work very well. So you can rely on this test. Of course, in many situations, in all the situations, you can use a passive degrading test. It is very easy to do. If you want to know more, it's not a heart-lung interaction test. This is why I will go fast. If you want to know more about it, there are some rules in this paper we published recently with Xavier. And you need a real-time cardiac output monitor to do. And this is a new meta-analysis, not yet submitted, with Xavier Monet and Paul Merrick. We pulled all the studies at that time, 24 studies, looking at the effects of passive leg raising about fluid responsiveness, and we found very good result. We found that the area under the row curve, or the average area under the row curve, was 0.94, which is very good for the prediction of fluid responsiveness. To finish, I just want to remind you that the decision to start fluid therapy should be based on the presence of hemodynamic instability or peripheral hypoperfusion, motile skin, hypotension, oliguria, hypolactatemia, etc., and the presence of preload responsiveness and limited risk of fluid overload. These are mandatory. These three items are mandatory. But the decision to stop fluid therapy should be based either on the disappearance of hemodynamic instability or appearance of preload unresponsiveness or appearance of fluid overload or marked increase in extravascular water, for example. So for the decision to start, it is and. For the decision to stop, or. So my conclusion is that heart-lung interaction indices can help to assess preload responsiveness, PPV or SVV, if the patient is mechanically ventilated with no spontaneous breathing activity, sinus rhythm, normal tidal volume, not too low lung compliance, and expiratory oxygen test when the patient is mechanically ventilated, but when PPV or SVV are not valid, and passive aggressing in all situations, including full spontaneous breathing activity. Thank you very much for your attention.